Last time we looked at some of the, we talked a little bit about health financing and things like that. And I hope that was useful. So today we'll just go a little ahead and look at understanding what equitable distribution really means, right? So because there's often some sort of this thing about what is equal distribution, what is equitable distribution, and things like that. So we'll just have a basic understanding of what equitable distribution means, and then I'll show you some ways of how you can maybe try to assess this. Next. Okay, so equal and equitable. Does anyone want to put in a comment about what the difference is or something like that? Please free to use your chat box to kind of get that. Is equal and equitable the same, basically? And we can unmute you also, or okay. So I'll just go ahead. So
equitable is fair and impartial.
Okay. Yeah, exactly. So equitable is fair and impartial. That is one way of putting it. So let's just go ahead. So right now, so we all know this reality that we live in India, and India sometimes people talk about it as a land of a lot of dualities. There is this, there's this what is sometimes referred to as the Bharat India divide, where you talk about issues like and these are actually two photos that I took from the net, and both of them are places in Mumbai. So, and these will all be actually geographically close to each other also. So it's like we live in a place where there is that kind of discrepancy that is there. So how do we address this? Obviously, can you have, there was a question the other day that, can we have equitable health in a country which does not have too much equity? That is again a big discussion for another this thing. But we all realize that there are two kind of parallel Indias that are there, where parts of it are far behind what we have currently. So I just want to introduce you to two people, and let's look at this. So one is Priya. She's a 20-year-old woman pregnant with her first child. Husband is a daily wage laborer, and they live 30 kilometers away from the city, and she needs to visit the hospital for her delivery, and the local bus or the cycle is her only mode of transport. And if there's an emergency, they can use their neighbor's van. And every time they visit the hospital, the husband loses a day's wage. Like last time we talked about indirect health expenses. So that's a form of indirect health expense, right? So then there is also the direct health expenditure and things like that. So that's one person. And on the other hand, you have another lady who is quite slightly older, 29-year-old, works as an advocate. Husband owns a local business, live a relatively comfortable life, has a fixed salary, has a easy access in terms of having a vehicle. There's paid maternity leave. So all of these things are also there. So uh, now, assuming that both of them need a cesarean section or this thing for their delivery, how would you go about it? Like, would you offer the same cesarean section at the same cost to both the women because it's exactly the same service, or do you offer different slabs to different women, with one woman paying a slightly lower amount? So there are different ways to how we will look at that, and that's something that we can discuss. So again, if we talk about giving one person the lesser, I mean, paying less and the other person paying more, is that really fair? So the way that some people have described equity really is this example with the stools, where both of them are trying to reach the books, but one person's shorter and one person's taller. So really, to get the same effect, that is to get to the same second row, you really need stools of two different kinds, right? So if you use the exact same stool for both people, sure, you're giving the exact same thing, but uh, does that solve the problem, right? So that's one That's one way of looking at it. And another really nice example that I've picked up from the internet is this example. So you have the tree which is bent in one direction, and you have someone trying to pluck apples from the tree. And if you look at it, the tree is bent to one direction because there are more apples on one side, and one person's on that side, right? The other side does not really have too many apples, and it's even further up. So then equality would be giving the same ladder to both of them, where both of them can't. I mean, it's the exact same ladder, but it doesn't solve the problem because only one person can reach the apples, where then the other person cannot. This thing. Equity is more like you give a taller apple to. I mean, you give a taller ladder to one person and a shorter ladder to the other person, and so they can both reach the same. Justice is probably in terms of larger structural changes very difficult to achieve, where you kind of try to make sure that the tree itself is straight. So it's a very abstract example of what we want to achieve in healthcare, obviously, because it's not very direct example. We just watch this quick video before you go forward, just so that you get a slightly uh,
The winner of this race will take this. It's a $100 bill. Before I say go, I'm going to make a couple statements. If those statements apply to you, I want you to take 2 steps forward. If those statements don't apply to you, I want you to stay right where you're at. Take 2 steps forward if both of your parents are still married. Take 2 steps forward if you grew up with a father figure in the home. Take 2 steps forward if you had access to a private education. Take 2 steps forward if you had access to a free tutor growing up. Take 2 steps forward if you've never had to worry about your cell phone being shut off. Take 2 steps forward if you've never had to help mom or dad with the bills. Take 2 steps forward if it wasn't because of your athletic ability, you don't have to pay for college. Take 2 steps forward if you never wondered where your next meal was going to come from. I want you guys up here in the front just to turn around and look. Every statement I've made has nothing to do with anything any of you have done. Has nothing to do with decisions you've made. Everything I have said has nothing to do with what you've done. We all know these people up here have a better opportunity to win this $100. Does that mean these people back here can't race? No. We would be foolish to not realize we've been given more opportunity. We don't want to recognize that we've been given a head start. But the reality is we have. Now, there's no excuse. They still got to run their race. You still got to run your race. But whoever wins this $100, I think it'd be extremely foolish of you not to utilize that and learn more about somebody else's story. Because the reality is, if this was a fair race.
Yeah. So that's basically, I know it's a little dramatized, and maybe may not be 100% applicable to us, but it gives us a kind of sense that it's gives us the kind of sense that it's not everyone starts at the same place, right? So when it talks about equitable distribution, it's more about trying to get uh, getting people on the same level. So that's one. Next slide. Right. So this is so how do we solve that, right? So how do we solve this big issue, right now, till now, whatever I've told you is very abstract, very philosophical, and all of those things, but that's not really the point, right? I mean, we know these things. I mean, all of us have some amount of experience, and we all know that this is it is kind of unfair. So how do we solve these things, right? So one thing is probably something called patient to patient subsidy, where you kind of what you do when you cost health services is you have private rates for people who can really afford to pay high rates. Some people, you have a regular rate, which is actually your minimum price that you would spend, plus maybe a slight profit. And then concessional rates is maybe like the bare minimum you have to charge to keep your system running. And some people try to operate in terms of department to department subsidies. So, for example, if palliative care generally is not a very profitable department, so to speak, but uh, there may be other departments that may generate revenue, like maybe in orthopedics or whatever. But so those departments that generate revenue, or those kind of departments, can actually cross subsidize care for departments that are not really going to be, that are more focused on outreach and things like that. So that's one way of looking at it. The other way is patient to patient. Free services is another big this thing, because some people say that having user charges at the hospital level is this thing. But the other question is, when you offer something for free, sometimes it's perceived as cheap, when sometimes it's perceived that it doesn't have, like, for example, immunization. Like, it's the government offers it for free. I mean, I'm not talking about COVID immunization, I'm talking about all immunization. So sometimes we kind of have this feeling that, anyway, the government gives it for free, how much value does it have? So that's one thing that comes with free services. But the flip side to that is it makes things accessible. So that's also a good thing. But whatever said and done, I think I want to take you back to our previous session that we had last week, where we talked about all of these different financial models, because ultimately your system has to be financially, uh, s- you know, has to be financially sustainable. So these are some of the ways that you would, cross subsidize care from different these things. If any of you have uh, if any of you can if you have, I mean, I'm sure that all of you have a lot of opinions about this. There's not one right answer, I would say, but these are different models that you could try. So I just want to talk about a general process that we learned while we were taking a case history, or to factor in different social factors. This comes from a very community health point of view, not necessarily a very palliative care point of view. So bear that in mind. But I just want to talk to you about how we were taught, or how I would kind of approach factoring in social things. It generally is a little more systematic approach. It's all the things that I'm sure all of you are already asking, but maybe a little more systematic form. But of course, having said that, I want to make it clear that these are just suggested. This is a suggested outline, and I'm sure a lot of people here have a lot of experience. They have a lot of. I mean, this is a group that obviously has a lot of experience among yourselves. So I'm not going to say that this is the only way you can ask these questions, but these are some things that I feel work for me. So hopefully will work for you. So you can go through my presentation, and then we can all learn together. That is the purpose of this session. It's not to tell you that this is the way to do it. Just before that, I just want to point out that for this kind of an assessment, generally it has to happen in a home setting, because a lot of these things have to be observed. So I'm going to talk about assessing the environment and things like that, which really won't make too much sense if you're asking all of those things at a clinic setting. You may be able to ask, but always it would be best if it could be happen in a home care setting. May not always be possible. And some of these findings can be you need not ask the patient. It's more of observational findings. And the other thing is that whenever you approach, these kind of a social kind of a this thing, it's always important to keep biases aside, because all of us are part of the community. All of us have grown up in the community, which means that we all have some amount of, influence of various things that come into our personal these things. But when you're approaching this professionally, then it's always better not to get judgmental and not to get personal with these kind of things. So, that's just some this thing. So yeah. So just a brief overview. We're just going to go about 10 things. One is getting information of the area where the patient is, some general information about the patient, looking at a few social schemes, some details of the family, some socioeconomic issues, health system issues. How do you look at the environment? How do you look at nutrition? Your clinical findings, I don't know if it's relevant here, but another thing is something called ideas, concerns, and expectations of the patient. Right. So the first thing before we go ahead, maybe assessing, getting information about the area, right? So why do you want that? So if you know the name of the first broad thing you want to be looking at is what kind of a setting is it, right? So there are different kinds of settings in community health or in the areas that you're working in. One is obviously the urban setting, where I'm sure a lot of you are. There's the urban slum setting. There's the rural setting. There is the tribal setting, right? So depends on where you work. There will be different approaches that you may need to take, but that's the broad overview of the setting. And inside that setting, if you know where the area is, right, then it really helps, because you can ask the questions: is there a known endemic disease in this area? Are there known outbreaks in this area? Again, more I'm talking about from a general health point of view. Again, outbreaks, it will help. Even if it's palliative care, it's always good to know these things. So again, in the recent past, and because we've already talked about COVID, if you know the area, you'll kind of know if it's a containment zone or all these fancy words that used to come across in the recent past. But though that kind of things, that helps with your name of the area. It always helps to know which is the nearby PHC, because obviously this is a government. I mean, there is a government system in place. So if you know which is the nearby PHC to that area, it will be very useful, because especially because the PHC is kind of plays a role maybe in kind of coordinating the care in that area and things like that. There may be a ASHA worker who is responsible for that area. So if it's some other kind of system, there may be other health workers who are associated with that PHC. So always knowing the government PHCs that are in your service areas, wherever you're practicing, kind of helps. And not necessarily PHCs, also maybe some private or other healthcare providers. So, for example, if you know which are the nearby medicine consultants, or your nearby physiatrists, or a psychiatrist who lives nearby. If you know these kind of things, that what are the resources, that really helps, I think, in the longer run. But these are things you can't necessarily ask the patient. I mean, you can ask the patient, but it's also things that you have to know also. One thing, again, especially in palliative care, there's a lot to do with transferring patients, shifting patients, and all of those things. So again, the distance from the main road becomes quite important, because sometimes patients can have very similar. They can live in exactly the same socioeconomic status, all of those things. But if they live quite far from this thing, it's not easy to compare someone who lives very far from the main road with someone who has a bus stop right there, right? Because there is a difference. So, and I mean, I'm not saying you need to ask it for every patient. It will be a patient, it will be significant, but it's always nice to note that down and keep, because you kind of have an idea and you can actually make those decisions later in the future if you need to, right? Type of road is important for access issues. So, will a vehicle that can vehicle that especially when it comes to shifting the patient, right? If it's a mud road or if it's, very hilly area, it may be difficult to shift that patient. So, even in your treatment styles, you may need to factor that in, because you may not want the patient to come to OPD a lot. You may want to, things like that will come into play. Next slide. Yeah, this, I don't know how relevant it will be for a lot of you, but this is a reality in a lot of rural areas. And I wouldn't say only rural areas, but it's good to have knowledge of what is the dominant caste in your area and things like that, because there is a lot of caste-based issues and things like that. I don't want to get too detailed into that, because that's another tangent altogether. But it's always, it may not make too much. If it doesn't make too much sense in your area, then it's fine. But if you're in a if you're in a if you're in an area where, if your setting is a kind of setting where these kind of things come into play, then then it's something that you may have to keep in mind. Because in a lot of villages in India, even today, there is a main village where you have your higher caste and you have a colony where you have your lower caste. So these kind of dynamics will come into play when it comes to healthcare. But I wouldn't get too much into it at this stage. But next slide, next. But it's important to keep that in mind. I'm not going to say that it makes a. Because access may be a little different based on wherever they're coming from. Then obviously we want the patient's name, age, all of those things, general information about the patient, type of family, nuclear, joint, three generational. Does it make too much, no, joint versus three generational, I don't think makes too much of a difference. Typically when you say joint family, you're talking about two siblings who live with their families together in the same house. Three generational is when you have one couple and then maybe one parent or something like that. But that doesn't make too much of a difference. But again, that will come where that the significance of that type of family will come is because support systems kind of vary. Because if it's a nuclear family, sometimes you may not, the pressure on one particular caregiver may be more. Whereas with a joint family, maybe there may be more people there to take care of that patient. So those kind of dynamics will come into play. Uh, but again, religion, caste, or those kind of things may come into play at some point. Next. So it's always good to note those things down. I'm not saying you necessarily have to act on them, but it's nice to know. Then again, some social schemes that you necessarily need to be aware of is, maybe, do they have a ration card? uh, which color. So many times we kind of think about APL, BPL, all of those things, but more easier than that is actually to ask them, if you have a ration card, what color is the card, right? I'll just get into that in the next slide. But before that, also, do you use the public distribution system? Because uh, again, in palliative care, we talk a lot about the patient having nutritional needs and all of those things, so they should not go hungry, right? And many a times, many of us may be in settings where we can't directly provide food or something like that. So if they have a ration card, if they have the PDS, definitely good to know. If they have a government medical insurance card, in Kerala it's the RSBY, Tamil Nadu is the Chief Minister's Health Insurance Scheme, Maharashtra Jyotiba Phule card. We went through this last time, so I'm not going to get into it. But do they have it or not? Right? That's something nice that you can know. Next slide. Again, this is just a brief this thing about ration cards, in case you're not very familiar with it. White is generally a non-priority card. Again, this is for Kerala, so I don't know about the other states. Other states have different coding sometimes, so you just have to be. You can go to your nearby the PDS of your respective states and look at it. This is something that I saw from Kerala. I'm not sure if the KG thing is correct exactly, because it may have changed. It was from 2017. But again, yellow is the most poorest of the poor, pink, blue, white. So kind of, if you know that, you kind of have an idea of where they are on the so-called. So it's one way to assess how well off they are, maybe. So, but again, the 2 kg rice per at rupees 2 per kg, I'm not very sure if it's still the exact same values, but that's generally the way you look at it. Yellow is something called Antodaya Anna Yojana. It's called an AAY card. AAY card is actually the people who are considered poorest. So they have sometimes they have, I think, a larger amount of rice that they can claim and things like that. Next, yeah. So this is kind of like a table that you could draw if you want to draw. I'm sure some of you draw it, some of you, I mean, but that's okay. But one thing is, so basically what's important to know is the education levels, one, because you kind of know education also goes a big plays a big role in how much how much access to the rest of the system they have. So education, of the highest education in the family, can be noted down there. So then there's health status in the family. So especially whenever you approach this kind of case, what we were taught is that you look at it, especially even in palliative care, is that you look at it as a family case study with your patient as the index case. So you are going there for one patient, but essentially what you're doing is you're looking at the whole family. So this kind of thing will help you put it in perspective. This kind of table will help you put in perspective, like uh, so does any other people in the family have other illnesses and comorbidities? So then you can address that also maybe. If there's any pensions that they're receiving and all of those things, it will help. So this is actually what something called the BG Prasad scale, where one of the easy things that you can do is you can look at total family income. You can divide that by number of members in the family. Very simple scale. Look at the total family income divided by numbers of members in the family. There are ways to calculate. So this is the current split. But if not, I can send you one. There's a website where you can actually go and you can actually classify them based on how much they are receiving per person, and based on that you can classify them. Not very necessary to do, but it helps perhaps in the long run. Monthly expenditure pattern. This is, remember last time when I told you, when we were talking about catastrophic health expenditure, right? So catastrophic expenditure we defined as 10% of health expenditure being greater than 10% of total family income. So if you can actually chart that down as monthly this thing. So sometimes we are very hesitant to ask the patient these questions, but often what we'll find is the patient has no hesitancy in telling us these things. The hesitancy is more on our part to ask these things. So especially if you go there with, if they have called you there, then they'll be more likely to tell. But sometimes it may not be very accurate also, because off the cuff, if someone wants to come and ask you how much do you spend per month on food, you may not be able to actually get a very accurate number, but you have some sort of a ballpark figure. It's not accuracy is not the exact this thing. I mean, obviously we're not going to go and ask someone to show them exactly how much they spend and all that, but it helps us get a overall understanding of it, especially things like savings and debts is important, because if somebody is in a huge debt, then you kind of know that this is one of the issues that they're dealing with. I wouldn't say that you have to be very persistent on getting exact this thing. Whatever you do, you're going to get some amount of underreporting. No one's going to tell you exactly how much they are going to this thing. You have to take in mind that they are probably going to be reporting slightly less than what they are this thing, especially because you're going there to help them. So if they want you, a lot of people will have that this thing that if I tell it less than what I receive, only that they will help me. So those kind of things will come into play. But some people may over exaggerate what they're getting, because they want to, for status reasons. So all of these things will come. It's not that we should be blind to it and believe exactly everything 100% that it's the truth, but it gives us a ballpark figure of what these things are, right? So, and if health is more than 10%, then you kind of know that this is a bit of a problem. Again, so this is health system availability, right? So one of the things is you want to look at, is there a PHC nearby where they can access primary health, secondary health care? Is there a government medical college nearby? Are there private hospitals nearby? And especially because we are in palliative care, I would say, and if you're going as a palliative care team, also look at if there are other palliative care services nearby. Because is it available? Is it accessible? Like, there's no point if it's there and the patient lives in one very big, in one hilly area where he can never come and go and see, or he works from 8 a.m. So 7 a.m. in the morning to 10 a.m. in the morning, and he can never go. I mean, those kind of things will come. So is it accessible? Is it available? Can the patient afford it? Is it of a decent quality? If there's a PHC there which is not functioning, no doctor, those kind of things will happen. I don't know what kind of scenarios you are working in. Also, utilization. Are they going to the PHCs? Are they going to the government medical colleges? Other palliative care services also will come into play because, for example, you go and you visit a patient for palliative care needs, and you see that they are getting. There's another team from another place that's actually visiting them every once a week or something like that. So then, I mean, then you may not have the need to visit that patient, maybe, or maybe there's a PHC nearby where this patient can get some of their medications from, and you don't necessarily need to provide those medications. So different permutations and combinations, but it's just nice to have an overview of whether the patient has accessibility, availability, affordability of these particular things, right? So when you do a home visit, I think one of the first things that you could do is probably just observe what's there outside. None of these things are necessarily things that you would ask a patient, but just look, is there any accident prone area? Like, for example, is there, one deep one well that doesn't have any barrier of any kind, where, which is, an accident waiting to happen. If you have something like that where a child could easily fall over, and there is a child at home, then you have to be aware that there is something like that. Or if there's a very steep staircase with no guardrails nearby, I've seen houses like that where there's a steep staircase but there's no handrail there. So and it's a person with some kind of a walking disability, so those kind of things, they are going up and down, but it's very likely that they could fall. It's just an accident waiting to happen. Those kind of things, is it there, is it not there? Maybe you can change it, but it's nice to be aware of it. Street lights, is it there, not there? Are there a lot of stray animals around? Are there open drains around? Are there vector breeding sites around? Vector breeding sites would be more in terms of if you're looking for things like malaria and dengue and all that, but maybe not so much for palliative care. But again, if it's a very high mosquito area and if you have a patient who's completely bedbound, then maybe it may come into play even in palliative care settings. But again, from a palliative care point of view, if there's a disabled person inside, is there a ramp or a railing or something like that inside? If a patient needs to be shifted from there, is there some sort of a way where a bedbound person can be shifted in and out? If the patient is a very remote area where there's no way that they can get out, maybe then you have to keep that in mind before, when you're reviewing the patient next time. You can't tell them, come after 3 days for reviewing this thing, right? So that kind of a thing, you may need to keep those things in mind. So that's the external environment outside the house. Next, if you can draw a simple house plan. Not necessarily that you need to do. Some people are more visual. Some people like drawing it down, and so that they have an understanding. If that doesn't work for you, you could write it down. I mean, essentially, we're not architecture people. We don't need to really draw it perfectly. But if drawing it is going to help you understand the layout of the house a little better, go ahead and draw it. I mean, just because you're an architecture people, it doesn't mean that you don't necessarily cannot draw a house plan, right? So, uh, type of house, is it owned house, rented house? It makes a difference in terms of, it'll help you get a better picture. Then, is it a kacha house or a paka house? Is the floors uneven? Is there a lot of rodents around? See, again, the reason why I'm putting these questions here, or why the reason why we ask this, is because later on when you go down, these are specific things that you can possibly intervene, right? There's a lot of infestation of rodents. Maybe there's something we can do about it, right? So, or maybe there's nothing we can do about it. Depends on the kind of setting you are. But just noting it down, is it there, is it not there, then it really helps. I think it's a systematic way of kind of asking those questions, just to know whether it's there or not there, so that you can deal with it if you want to deal with it. But if you don't methodically note down these things, sometimes you may just forget that, to even ask those questions. That's the only thing. Thatched roof, tiled roof, asbestos, this thing. These days, you don't really see a lot of thatched roofs in my from what I have seen, I have not seen too many thatched, but I think asbestos is like the new thatched because everyone has one asbestos sheet over one, kacha house, and that is the, the house. So if that asbestos also can be extremely hot to be in, especially because when you have small children in the house, we've seen cases where, you have a child who's come with dehydration, you corrected the dehydration, send the child home, the child again comes back with dehydration because he's living under one asbestos roof and he's literally getting cooked inside that. So it helps in that kind of a setting. So is there any leakages in the roof? You do need not necessarily ask the patient that, but if you're doing a home visit and you just have a look around, you may have an idea if there's a leakage. I mean, these are not things that you necessarily have to ask the patient, and it's not things that you would take a lot of time to assess also. It's just things that if you have it as part of your systematic process, then you will note it down. That's the only thing. So again, is it the cement, mud? Is there a lot of cracks and crevices in the walls? Is there dampness? Dampness can be like for mold and things like that. If you have a really bedbound patient, and the walls are all moldy, I don't know if you can do something. Many times we may not be able to do anything for it, but if we can do, maybe we should do. So that's the logic in that. Uh, Now, this is overcrowding is something that would come into play, especially for a disease like TB or something like that. So if you're doing palliative care and TB kind of a setup, non-communicable disease kind of setup, overcrowding is something that you definitely have to assess for. But again, if the house is overcrowded, I don't know if we can actually give a solution. We can't, do something magical for, I mean, to reduce that overcrowding problem. But knowing if there's overcrowding, no overcrowding will probably help you in terms of this thing. How do you assess for that? One is next. There are some criteria that are there. One is, person per room criteria, where, this is generally accepted as the standard of this thing. So if it's one room, you can have a maximum of two people. And if there's, three rooms, you can have five people. So that's generally how you would, it's a very crude estimate of measuring overcrowding. Also, the other factor that there are some other factors that come into play in the sense that if it's an infant less than 1 year, you don't count them. A child less than 9 years gets counted as half, or and also in spite of all of this, if you have adults of the different gender who are who don't have separate rooms, then again it sometimes counts as overcrowding. So yeah. So then this is either you can go by total number of people. The other way is also you can go by total area of the house. Sometimes it can get a little tricky to estimate area because obviously you're not going there with a any means to measure the house or anything. But I think if sometimes you just know the area because your experience, that's the only way you will assess it. It doesn't have to be a very very accurate estimation of the area of the house or anything like that. Again, that's not our job. Our job is not in exactly measuring it perfectly, but it gives us a kind of idea whether there is overcrowding or not. Ventilation, again, very important for TB point of view. Now the dictum in ventilation is that again, why do we have to ask these questions from a healthcare point of view is because ventilation affects TB. Ventilation affects, again, COVID, and ventilation is again becoming a big discussion right now. I mean, everyone's talking about how we need increased ventilation in COVID and things like that. So again, these kind of things play a part. So uh, uh, so just the fact that we are from the medical profession or you are from social work psychological profession should not stop us from asking these questions. That is the thing. And so generally the rule of thumb is that your ratio of the window space to floor area should be 1/5, and the ratio of doors plus windows should be 2/5 of the floor area. And you need some amount of cross ventilation. That is, you need one window on one side and the other window on the other side. If it's not there, then you have a problem with ventilation. Again, as a hospital, if as a social worker, as a psychologist or something like that, can we do anything to improve ventilation of a patient's house? I don't know, but we could point out that there's a problem with the ventilation, and maybe a volunteer could help do it, or maybe they themselves could do it, or there are ways. It's not impossible. Indoor air pollution, again, that is something related to the kitchen. I mean, if there is cooking inside the house with the wooden stove and things like that, then you could indoor air pollution would come again into play when you're looking for diseases like TB or not only TB, anything where there's indoor air pollution, you can have a lot of lung related issues. Lighting, one way to assess lighting is the lighting advocate is they say that you should be able to read newspaper print in any part of the house. So if you're able to read a newspaper inside the house, generally you say lighting is okay. Again, a very, very rough estimation. You're not really calculating it or using any instruments to measure it. But if you can read newspaper print, find newspaper print inside the house, generally you say lighting is okay. Again, this is also from a very community health point of view. So also, and these kind of things would make a big difference in the quality of life for someone who is fully bedbound, right? So if he's, has to live his whole life in one very dimly lit room, I don't know, it may be a little sad maybe, but kitchen again, is it inside? You may find some of these rural houses where you have wooden stoves or kerosene, I mean wooden chulas, what they call inside the living area, which is not a separate area at all. So if it's inside the living space, is there a way to kind of put that out, especially if there is a bedbound patient? These kind of things come because you have a bedbound patient there and there's all smoke coming onto his face all the time, can get quite difficult for that patient. Again, how do they store food? Not very important for us. I mean, not very important for us in the sense, but it's always nice if you know. So, those are some things that, from a community health point of view, you would ask. You can feel free to ask that even from a palliative care point of view. But water supply issues, uh, this is something that some places have water supply only for 2 hours a day, 3 hours a day, something like that. Some people may have 24 hours piped water. So thing that will also come into play when you talk about medical issues like maybe constipation or loose stools and things like that. Sounds like a very, very, very silly, trivial thing. But the fact that there's a 24-hour water supply really plays on this thing. From a public health point of view, again, that also plays this thing in terms of whether there's waterborne diseases and things like that. But even from a palliative care point of view, the toilet and the water supply and all these things make difference in terms of, especially if you have, because we are talking about symptomatic management of things like constipation and vomiting and whatever. Again, inside this storage, these are things that are easily correctable, right? If someone's storing water in a vessel that's largely open, again, this is not something that you're going to go and ask the patient, do you store it? These are just observations that you probably have to keep an eye out for, right? It's not necessarily that you're going to go and ask, how do you store it or whatever. But a lot of people take water by just dipping it in. Sometimes if the container that they use is generally very dirty, sometimes you can have waterborne diseases and things like that. Very correctable things, so it can help. Bathing area, again, bathing area also becomes important in terms of access. Very important from a palliative care point of view. Are there accident prone areas there? Because if you have a patient who can barely stand up and you have a accident prone area right there in the bathing area, it's you're just, and it could be an accident prevented, right? And next, yeah, so again, same things that I mentioned for constipation, vomiting. If the next, yeah, these are again things. So these are all part of general questionnaires that we use. This is all part of a questionnaire that we used to use. So I just wanted to share that these things can be asked. Hand washing practice is also important. Is there a, this is not something that if you go and ask the patient, do you wash your hands? Or do you wash your soap? Do you wash your hands with soap every time you this thing? They will tell you yes. But it's also about, if you see the bathing area and you see the hand washing area, there's no soap sitting there. then you kind of have an idea of whether it's there. And these kind of things play a more important role from a communicable disease point of view. Maybe not so much from a, it does play a role from a palliative care point of view also. Laterals, again, the important thing is if the patient is not bed bound, can we solve this issue by a simple commode chair? Like, again, sounds very trivial, sounds very something that's easily solvable. But if a lot of these things are not available and the patient is not able to go, it's not a very the access is not good. Maybe you could just solve it with the commode chair, right? So that's again issues that can be solved. If we can solve it, that's good. Waste disposal, how is the waste disposed? I won't get into that too much, but again, are they burning the waste? Are they just letting it be there? Is there a lot of foul smell in the area? Again, from a quality of life point of view, it makes a difference. Next. Yeah, so all of this actually is important from a communicable disease point of view more than a palliative care point of view. But again, I think it is important in the sense that if there is a waste problem there, and because of that you have a lot of stray animals there, and because of that you have a risk of a potential palliative care patient getting into an accident or something like that, then maybe that is something that should be addressed. I'm not saying that necessarily we as the social work team or the psychology team or whatever can address that directly, but just being aware of this problem can, somebody can address it. I mean, somebody can address it in the sense maybe you can reach out to someone who can help in addressing it. So if it's assessment for vectors, again, if there's rats around, if there's rodents around, if there's flies around, again, I don't know if we can this thing. But again, if it's a bed bound patient lying on the floor and there's a lot of rats there, then you're waiting for something like, I mean, a lot, in the slightly older, I have not seen a lot of cases like that, but I know of seniors who've actually talked about, you've seen a lot of patients people who should sleep on the floor and then come to the hospital with rat bites and things like that. So if that is an issue, and if that's an addressable issue, because right now there are a lot of ways, a lot of easy solutions for rats and rodents and things like that that can be applied. Mosquitoes, again, is there a vector breeding site there that's really going to cause discomfort, especially if there's a bedbound patient and there's a lot of mosquitoes around, a lot of flies around. These are things that, again, if waste disposal is not proper, you could have a lot of flies around. Again, a lot of discomfort for the patient. So very subtle things, not things that you would generally associate with medical professionals asking, but uh, if you can look at it, it's good. If you have the time and the ability to ask these questions, it's good. So dietary practices, I would not go too much into that currently, because that is quite nutritional assessment can be quite complex in the sense that there are scales and tables and all that you can use to look at amount of calories consumed, amount of proteins consumed. You look at if there is the deficit and then you try to control that. Especially important if it's a pediatric case, or if it's a pregnant case or some. I mean, especially in children and things like that, you want these kind of things to be really sorted out. But they will also play a role in maybe in terms of if there is a diagnosis of cancer or whatever. If there's a chronic disease where nutrition plays a role and there is a calorie deficit there, maybe it can go. So there's something called the 24-hour recall method that I want to talk about. So the 24-hour recall method is not very complicated in the sense, but it's not like you don't ask the patient what you eat on a typical day. You ask the patient, what did you eat today for breakfast? What did you eat yesterday night for dinner? What did you eat yesterday for lunch? And you kind of try to take measurements, approximate measurements of how much it was, 100 grams, 200 grams. Then you calculate the number of calories they get from that, and you kind of calculate how many calories, how many proteins, what is the requirement, what is the deficit, or how much excess is there. And if you can do that, that's great. Also important for us is maybe average number of meals consumed by person per day, because especially there's a lot of you may have houses where they're not getting even enough food for this thing. So dietary practices can come this thing, but there are other ways to measure nutrition. Like there are things called consumption units and things like that, but I don't want to get too detailed into that because that's a whole other this thing. But this is just a way. I'm sure a lot of people have heard these terms, and I don't want to bore people by talking about too much of that. But this thing, if there are children in the house, we would look at anthropometry, that is measuring height, weight, BMI, head circumference. So that would be important from a but that's not necessarily if you're clinicians or some. I mean, I don't know who typically does that. If there are people who are nurses or something like that, that's important. But the point is, it's important from a point of view of screening for malnutrition for children. So even if you go to a house and you may be going to the house for a palliative care patient, but if there is a clearly malnourished child in the house, right? So ideally, you would measure anthropometry for each child. Anthropometry is basically height, weight, BMI, head circumference, chest circumference, mid-arm circumference. It's basically looking for malnutrition. So if you have a malnourished child in that house, then if you're going there for something else also, and if you can screen for this, then it's generally nice. But I don't know if, again, like I said, these are things that uh, it's easy for me to say, but again, it's with how much of it can you impart in your practice will depend on your setting. Ideally it should be done, but if it cannot be done, I don't know. But if there's a child who is obviously looking malnourished, maybe you may need to try to address that by, I don't know, sending them to a pediatrician or nutritionist or something, or maybe arranging some food for the child, something, anything that can be done. Next, immunization status also same. If there's a child at home, again, like I said, this is more from a community health point of view. So great to know if there are any unimmunized children at home, because especially if you're working in tribal or rural settings. Tribal settings, especially, there's a lot of possibility of a lot of unimmunized children at home. So if you can get them, I mean, if you notice that there's a gap in immunization, if you can refer them to a nearby hospital and get them immunized, nothing like it. But again, not very much necessary from a healthcare point of view. Clinical examination, again, I don't want to get, it's the routine clinical examination that anybody would do. So that's okay. Now this is something that's quite important that I feel, that is, it comes from a, not from a community health point of view, but it comes from a family medicine point of view, where you talk about ideas, concerns, and expectations of the patient, and ideas, concerns, and expectations of the family, right? So ideas is basically, what does the patient think of the disease? What, people have, I mean, what does he understand by the disease? It's like insight, right? Some people, a lot of you use insight of the patient. So it's ideas, what the patient, some people may think that they got the disease because of certain things. All those sorts of ideas, you can put that there. Concerns is basically what are the patient's concerns, right? So a lot of the times what we see, or what we this thing is, the doctor assesses the patient, but uh, the concern of the patient will not be what is the doctor's priority, because I mean, it's not done out of malice or anything like that. It's done out of good intention only. But unless you address the concern of the patient and of the family, they're going to be very unsatisfied. So try to find out, when you're talking to the patient, try to find out what is their real concern. Like Dr. Raj sometimes says, it may be, even if it's palliative care, the real concern may be what happens to my children or something like that. So what is their concern of the patient, right? And what is the expectation of the patient? Does he, maybe somebody who you're seeing post stroke, maybe that patient may not really have a realistic opportunity to get well better. I mean, get fully 100% power, get back to completely normal. And we know that it's not possible. So sometimes, you may see, where the hospital, something that sometimes, we know that there's nothing more that can be done. So you say, you just go home. But or they may be be doing physiotherapy with the expectation that, they're going to get back 100% of the power. But actually, realistically, we know that that's not the this thing. So right, if we can actually find out what do the patient expect, then that really helps us to kind of get that communication right. Obviously, this is not a communication class, but if you know what are the ideas, concerns, and expectations of the patient, and ideas, concerns, expectations of the family, so writing it like that when your case sheet, ideas sometimes helps get that clarity. A lot of the times we ask these things. I'm sure that most of us, especially in palliative care, we're asking these things. But if you can note it down like that, then you're forced to ask that question, right? Because you have to fill that particular format. So then that may help in the process. But again, each person has their own process, and many of you may have developed your own processes out of years of experience. So I'm not saying that that is this thing. I mean, this is just my way of looking at it, or whatever we've been trained in. So it's just about learning from each other. That's it. Okay, so at the end of all of these questions, right? So we have to make some sort of a summary, some sort of a understanding of what we are going to do, right? So otherwise, what was the point in asking all these things? So, uh, so one thing is maybe your clinical aspects. If you are on the clinical side of things, maybe it becomes necessary to you. So you maybe put down your so if it's a young index patient who has had a stroke, maybe may talk about things in terms of aspirin and all those medications, maybe a physiotherapy referral. If there's a malnourished child at home, again, you want to look at the clinical side of addressing that malnourishment, something like that, so all your clinical aspects. Apart from that, you've also asked about things like financial assessment. Asked for debts, you've asked for these things. And uh, so in that kind of things, when it comes to financial assessment, and you see that there's somebody who is unemployed at home, or somebody who's they're not able, they need the income but they can't go out. So can there be something like a vocational training that we can do? I don't know. Maybe you can arrange it. Maybe in the setting where you cannot arrange it. That depends on your setting specific thing. Maybe there may be a NGO nearby who does things like that, right? That's why I asked you know the health resources nearby. So can you help in that kind of sense? So if there's a malnourished child, can we arrange a food kit for that patient? Can we arrange this thing? These are questions that may not always have the answers we like, but and especially when it comes to social work and these kind of things, I personally believe that the clinical side of things is the easy part, because you have treatment, you have management. But to get results in the terms of the other aspects, psychosocial aspects of it, is very difficult. So if you try and try and try, you may get a few successes. Don't let that dishearten you. Just keep doing it. So again, and one is especially in terms of financial assessment and all, it's one thing to know what is the problems the patient has, but it's also important to know what the strengths of the patient has. So if he has access to a good PHC, or if he has access to the best, good hospital, so those are also strengths. Those are also things that you can write down, right? So those are things that where you can say that okay, fine, this patient has access to that, so maybe I don't have to spend. Or he may be eligible to get a wheelchair from somewhere else. So maybe you don't need to provide him a wheelchair. You can help him get that wheelchair from somewhere else. So then you can actually use that for somebody else. So that's where you come back to this whole idea of equity, where you kind of uh, rationalize how you spend your this thing. So this helps. So so yeah, so next slide. So and never will I say that it's all about being 100%, everything the patient wants. It's also about how we assess what would be a this thing, how we could use those resources. So environmental aspect, like I said, there's a steep stairs with no railing. Maybe you could construct a ramp. Maybe there's a toilet present, but it's not accessible. Maybe a commode chair will help. So see, these are all things that we always that a lot of us do. But it's not, may not be in a very systematic method. So just kind of putting it in this order sometimes helps us to get our thoughts together. That's the only thing. It's not that these the things that I'm saying here are brand new and nobody has ever heard of it. That's never the aspect. Why everybody has experience, and they know these things, right? So health system related these things. Is there somebody else who's coming there for home visits? Will the patient be able to afford going to the OPD? Are they going to lose? So those kind of things will also come into this thing. Dietary aspects. Can we offer supplementary food? Can we connect them to government schemes for malnutrition? Or maybe the patient has access to all of these things, so you don't need to do anything. Next. Transport and mobility assessment, is it far from the main road? Sometimes you could offer a travel allowance. Sometimes the patient may say, I'm willing to come, but it's very far. Maybe if I get a travel allowance, maybe I can come. Or maybe the house doesn't have a ramp, or maybe they don't have a wheelchair. So maybe that's something that we can help in. So psychological aspects, again, very difficult to solve. Uh, Post stroke, they will be having some some but can we connect them? Of course, a lot of people here are psychologists by training, so I will defer to you and to your expertise in this thing. But can we connect them to someone who's a psychologist, or can we connect them, or something like that? So can we do that? Because a lot of times you have people who have these kind of needs, but they cannot really access a mental health professional. So these are things that we can, if we systematically ask for it, it really helps us in our practice. uh, Again, vocational training, the reason I put it under psychological aspects is maybe because the if you give someone a vocational training to do something at home, sometimes it may not fetch them a lot of money, right? It may be very it may not really be a lot of money, but sometimes the fact that you have given them something to do gives them some sense of purpose and gives them some sense of feeling that they are recovering from it. So it has both the financial side of it, but it also has a very psychological side of it also. Caregiver aspects, do you have someone at home who can take care of the patient? Is the person who's taking care of the patient so worn out with taking care of the patient? Can you consider a role, a paid caregiver? Do they have this means to do that? I mean, I don't think we need to look at the concept of paid caregiver in a very negative light, because sometimes it depends on the situation, right? It's depends on if it's needed or if it's not needed. So again, it's so is there anything that we need to do for that caregiver? So again, it's important to look at strengths and weaknesses. Sometimes some families may have excellent support structures, a lot of people at home who are willing to take care. That's a strength, right? You don't need to worry about it. So maybe you may have a lot of psychological support, so that's maybe there may be a psychologist in the family, so those are all strengths. So you don't need to look at it from this very perspective of all this is their all their problems. And I mean, of course, I put the heading problems, which is probably not very wise of me to do, but it's also the I would say domain there, right? So it's also about what their strengths are. So again, at the end of it, what are the felt needs of the patient, right? What are the felt needs of the patient is what does the patient feel that they have come to the hospital for? Because sometimes the patient comes to the hospital for, like I said, ideas, concerns, and expectations. Have we met those needs? Because and but not everything the patient feels or the caregiver feels is necessarily that we can provide or that needs to be provided. There's also a bit of the social workers and the clinicians or their point of view as to what is really needed. So you put these tools together, you kind of work out what is the practical, logical solution, what is a thing, something that can be done, because there's no point in kind of thinking that we can solve all the problems in this world. All of us have that. I think we've all have some experience to say that we can't, but and more often than not, we will fail in solving these problems. But at least sometimes we will succeed, and that I think for me is worth the effort. So that's next slide. Again, the credits. I've taken a lot of content from what we have learned that my training was. So a lot of my slides or a lot of my these things were directly taken from there. So I just wanted to give that credit also. So I'd be happy to discuss, because these are things that this is my way of looking at it. But I'm happy to it's about learning together. It's not about me telling you that this is the solution.
Thank you, Doctor, for that wonderful presentation. So we can have a question answer round now. You can share your comments or your experience in your setting. So we'll start with Prasanna Sriya.
Yeah, but this is totally from a different context. Uh, I started seeing the world through my son. He's into nature and wildlife. So there's something called Earth Hour, where on March 28th, it started in Australia. Basically, you switch off the light from 8:30 for a 5-minute or a 10-minute period. And it started, the moment started spreading everywhere, meaning everybody in all the countries started following the system. And when it came to my turn, I was volunteering for WWF, World Wildlife Fund for India. And I started talking about this Earth Hour to my community over here, which is fairly big, which is just 4 lanes, but they were well aware. And it was a mixed community of fishermen hamlet. I live close to the beach, as well as the affluent. And that was the day it was an eye opener for me, meaning I went door to door and I did this campaign. And there's a, Kalyana Mandapam. So people gathered there, and from there we go we chant for the Earth Hour. And we ensure that people, whoever have understood the concept, switch off the light. And we went on as a parade on the road, on the streets, from street to street. And only on that day, I could actually appreciate what actually doctor spoke. No, it made a lot of sense, the disparity, because people who were living in the flat and individual houses, they knew what it was and they were able to do. But our march and walk took part even in the fishing hamlet. So it was for what we were consuming as the air conditioners, as the refrigerators. So on what basis could I ask them to switch off the light, even if it was for 5 minutes or 10 minutes? It was actually wrong. It was an eye opener for me. I hope you're able to understand the analogy. But I understood the meaning of disparity only on that day. Until then, I felt the world was same. Thank you.
Thank you for sharing that. Yeah, that makes a lot of this thing, because I think it's also about us going out into other communities and getting some exposure to that. Maybe with a willingness to learn from them. Then I think it broadens our perspective. So that's important. So thank you for sharing that.
Your MD community, is it? You did your community. So in that, I just wanted to ask you, so what motivated you to do community medicine? I wanted to do community dentistry, but there was nobody to teach, and it was very dry. And during my time, 1997, it was not a big branch as such as community medicine. But I would want to ask you, what inspired you to come into community medicine?
I don't know if there's one single answer to that, and I don't know if that's this thing, but that was a subject that I liked from undergraduate, so that's one of the reasons. But yeah, but again, it's not a. I mean, it had wrongly has a notion that it's a very dry and boring subject. So I would like to alter that.
Thank you, Doc.
Because again, everybody thinks that we talk about flies and we talk about toilets, but again, it's important from this point of view. So again, like I was saying.
Yeah, thank you.
So anyone else wishes to share your experience? If you want, you can unmute from your end and speak. So we heard a lot about equality and equity and all. So how was it in your setting, in your place there?
It's Prasanna again. So in my side, I think I expected an ideal world, and I saw the world has shades of gray. I've still not accepted them. I'm 47 years old, but I still not accepted it. I'm still looking forward to meet at least people like me, So I met one community medicine MD today. I'm so glad. But yes, I saw more of disparity wherever be it the settings. In my case, it happened with my dad. So though he was stage 4 of multiple myeloma, uh, nobody told me about the stage 4, meaning there's no staging per se. But considering his age, at least they could have allowed him to be peaceful. So more treatment was given. And when they realized there was no insurance, so that was the time they were ready to let go of us. They said, "Oh, I don't think we can do much. It's best that you discharge and you take care of him at home in a nursing setting where nurses can come and give the drips or the medication or the measuring of his input and output of food and liquid intake." So I understood what insurance meant and the disparity, even whichever class you may be. You have an insurance, you treat it differently. You don't have an insurance, you're discharged immediately. In fact, they want you to go right away because the bill kept going up, skyrocketing. They were scared that whether I'll be able to pay it and discharge him. So I saw it even in my own case of whatever you call. I don't know what class I belong to, middle class, upper class, or what. But on that day, I found myself with 0 class. I couldn't digest the fact, though I'm a dentist myself, then I thought about the people who are illiterate and the people who can't even afford. I didn't know. So I just thank God for at least keeping me in the place where I was. I discharged him and I brought him back home until I found palliative care, which was very close to my house, hardly 5-minute drive. And my dad was perfectly fine for the 2 weeks that remained of him. So that was my experience.
Thank you, Prasanna. Really feeling bad to hear that experience. But as you mentioned, like we all will strive for having an equity in this world.
I'll meet you too then.
Thank you.
Hi, this is Vandana.
Yes, Vandana.
Yeah, so the disparity a doctor spoke about, I see it so often at Tata Memorial Cancer Hospital. And there isn't anything you can do about it. I mean, sadly, you can't do anything about it. Even if I go by the process that we discussed in the presentation today, there is still nothing. There is actually nothing. Patients come in with a yellow card or or maybe an orange card, and we direct them to the Rajiv Gandhi scheme. And that's where it stops, because that caters for, say, for $1.5 lakh. Thereafter, what? Cancer treatment is so expensive. What happens thereafter? So whatever a doctor spoke about in the presentation is wonderful on paper. How do we actually put it into practice is what my concern is, because I don't see it happening. And I think that's also possibly because there is lack of integration, because it can happen. It's not that the country lacks resources. It's just that there is no cohesiveness. There is no, there's no interlinking. There is no process that from one department, the patient should be referred to another, to the third, to the fourth. Somewhere after Rajiv Gandhi, it stops. And if there are people like us, they approach us, because I'm associated with an NGO, we can still help them to a certain extent. But even that is at times not enough. For a medicine that's costing, like, say, suppose it's crizotinib, it's costing 80,000 rupees. We can't give 80,000 rupees to 20 patients in a month. How do we continue, how do we support the other patients then? So this is a huge dilemma, and I think it needs a lot of work, and I hope it happens. I mean, that's my perspective to today's topic, that there are too many roadblocks. And also the reach, even if, I, for example, want to help a patient who comes from a rural village in West Bengal, I can't coordinate for that patient. Where do I reach out to? I know Pallium India is in, Trivandrum. If there is something, I can reach out to Smriti or maybe Manisha or maybe Doc. and tell them, okay, this person needs help. But if there is a patient somewhere in Northeast, he comes to me, I counsel him, I help him with as much as is available at Tata. Thereafter, it stops. So the disparity remains. Even after we put in efforts, it still remains. So yeah, I mean, I find it a little unsettling, a little discerning. But sadly, this is the reality of what I have seen, because in terms of patient load, it is so much. It is so much that the NGOs are also sometimes their hands are tied. You can't go beyond doing certain things. So yeah, I mean, that's my take.
And I 100% agree, right? I have by no means, like I said, we will fail and fail and fail and fail again, because that's what I said right at the beginning. Can we really have an equitable health system in an inequitable world, right? So that is that. I mean, the idea was not to get philosophical about it, but it was also this thing that, if we try doing something somewhere for one patient, it may not be 100% solution, but maybe this assessment that I was talking about was more for trying to figure out who are the people who would need more. I mean, I know you don't really need this entire assessment to figure that out, but it was for that. But I 100% agree that it is extremely difficult to do, especially in a high volume hospital. So sometimes we have a luxury of having a smaller number of patients, so you can do a little bit more. But again, I agree. I was not trying to get philosophical about it. So yeah.
No, not at all. I'm just talking from my perspective, doctor. So, there are at times, I mean, I'm going to narrate a small incident. It was heartbreaking for me to see that. So there was a pregnant woman whose 3-year-old was diagnosed with ALL, and she needed, a certain amount of money for the treatment. Even through NGOs, it wasn't possible to get hold of that treatment. So the medical social worker tells that woman, unfortunately, I was standing there and I heard that woman being told, तुम्हारे बच्चे ने तो मरना ही है, पैसे तो नहीं आ सकते, your child is going to die. So instead, I mean, I probably will start crying when I narrate this incident. And to tell a mother that your 3-year-old is going to die because of lack of funds. So that kind of disparity does exist. And how do we bridge, how do we cater to all this is, I mean, yeah, it weighs on people like me, because I'm into palliative care, I'm counseling. And at that moment, you're actually inhibited, you are tied down with a lot of constraints that are there because of the policies of the government, or maybe because of I don't know, I can't really pin it on a single cause. But then I have seen this so often that, if there is somebody affluent who walks in, and that same person, same person with the same 3-year-old, same pregnant woman can get hold of a 30 lakh rupees. And her child gets the treatment. Whereas this woman coming from a BPL background, she's told this. So it is very, very distressing and very heartbreaking. So that disparity does exist. And I hope someday we can at least give the right to every Indian citizen, at least the right to avail treatment. What happens thereafter, we really can't, say. But I just so wish, it's just wishful thinking.
Yeah. That actually also takes us back to our last session there, where we were talking about things like this overall how do you cross subsidize overall in terms of getting your insurance things. But that's not policies that is in any of our hands. Those are more very, very higher up policies that
yeah, that's right. And I just hope we reach that stage one day in India, where every Indian, irrespective of where, I think probably it's very wishful thinking, but Yeah, I just hope that happens someday. I mean, the dignity to receive treatment, and as Dr. Raj would say it. Yeah, thank you.
Thank you, Nandarajan.
Yeah, I agree with what Sunita also said, because the idea is to keep getting up, and the more we fail. I think I was talking to someone recently and I said, as a social worker, if you, out of 100 times, if you know, are successful once or, you know, under 10 times, then I'm more than happy. So that is. Else who want to this thing, or shall we wind up for today?
I like the video that you shared, Doctor. The video that it made a lot of sense. I understood as the question started, as people were getting filtered, those were the deprived. It's not that they can't. They were never even given an option to. It's like you cut off your leg and you say, now you can run.
Yes, ma'am. Thank you so much. So I think we can wind up our session for today. Thank you all for joining in. Thank you, Dr. Deepak, for that wonderful session. So we will not be having a session next week. We are taking a module break, and then we will have our module from the next Friday onwards on marginalized communities, coming from next following Friday onwards. Thank you all for joining in. We are winding up. We'll see you after 2 weeks. Bye.